Welcome back, everybody. We're going to continue this focus on rural healthcare with a great panel of experts and providers who can help us not only define what the problems are with healthcare in rural America, they can also help highlight some of the solutions as well. First up, we have Dr. Yvonne Jonk. She is the Deputy Director of the Maine Rural Health Research Center with an expertise in health economics. Dr. Jonk also holds a position of Associate Research Professor in the graduate program in Public Health at the University of Southern Maine's Muskie School of Public Service. She was previously the Associate Director of the Center of Comparative Effectiveness Analytics at the University of North Dakota School of Medicine and Health Sciences and held a faculty appointment there. Our next panelist is Dr. Julie Yaroch. She's the president of ProMedica Charles and Virginia Hickman Hospital. Prior to this appointment, Dr. Yaroch served as a president of ProMedica Defiance Regional Hospital. Other positions she held include vice president of medical affairs at Defiance Regional, Bixby and Herrick Hospitals. Dr. Yaroch is a board-certified internal medicine physician. She is the doctor of osteopathic medicine from the University of College of Osteopathic Medicine at Midwestern in Illinois. Dr. Yaroch is a member of the American Osteopathic Association. And our third panelist is Ben Anderson. He leads Family USA's effort to improve maternal and child health. Anderson comes to Families USA from the Children Defense Fund in New York. While there, he developed and managed the organization's economic mobility and health policy portfolios, including leading coalitions and maintaining relationships with policymakers. Before that, he worked as a policy analyst with the Maine Center for Disease Control and Prevention, where he managed the rulemaking process. Mr. Anderson holds a BA in economics from Colgate and a law degree from Boston University. So Yvonne, Julie, Ben, welcome to the Rural Progress Summit. And as a reminder to the audience, we'll be taking questions through the Q&A window only. So please submit your questions there. And as we talk to our panelists, you feel free to just put in your questions. So with that, the first question, I'll go with, we'll go with Yvonne first. How do rural communities leverage their strength to ensure the health and safety of their communities? And what federal funding programs are essential for daily or to deliver of care, like the essential delivery of care?
Yes, well, this is a great question. So, rural communities really are very tight-knit communities in general. They tend to know each other quite well. And, I always said that when I left the rural community that I grew up in North Dakota, that it was quite obvious to me that no one was going to pull me out of the ditch when I, went during a snowstorm anywhere else, right? So I did miss that. It was a bit of a culture shock for me when I was in my younger years. But so these rural communities, especially when it comes to EMS, and trying to support their local hospitals and providers, they do tend to band together and to pull together their resources and really come at things with a grassroots sort of initiative. And there's varying success around that. We've seen the study that the Maine Rural Health Research Center put out last year in May around ambulance deserts. We really were able to shine a light on the extent to which there's a problem in really sparsely populated remote rural areas that it's really hard to provide adequate coverage, at least when it comes to ambulance services. And it's also a problem with having adequate access to healthcare facilities. So, for example, the standard yearly for access to care is around 30 minutes. And there are a lot of folks who live way outside of a 30-minute drive, to a hospital or a clinic. And so it's sort of part of the fabric of rural life is that, that you're going to have to travel a ways to not only pick up groceries, but to go see your doc and etc. But still, it is concerning because when it comes to a life-threatening condition, how do you get the care that you really need? So rural areas tend not to be so, very well resourced. They tend to be of lower income than their urban residents, and that's across the board. So employment opportunities are lower, et cetera. But in terms of, I want to get to your next question about, the federal programs. So we have a number of state and federal initiatives. So, for example, the state offices have not only state EMS offices, but we have a state office of rural health in each of the 50 states that are funded by HRSA in part, and they were also we also have programs that support critical access hospitals like the Flex Monitoring teams. And so there are initiatives around workforce. So, for example, the AHECs are really tasked with trying to ensure that we have a pipeline of folks moving, out to rural areas to serve the needs of those rural residents. We have rural scholars that are trying. We have debt forgiveness, for our medical school candidates that are contemplating moving out to rural. So if they serve in rural areas, there's some loan forgiveness around their schooling costs. So those are just a few examples, and I'll let the rest of the group chime in.
Yeah. Well, one thing I want to, before I go to Julie, mention is that Palo Alto County, near where I live here in Iowa, is declining at a rate that by 2050, if it continues on that path, it'll be depopulated. And I went to a meeting where they were arguing to keep their one ambulance and trying to figure out how to pay for it. So like that really hits here as much as anywhere. So I'm glad you brought that up. Julie, do you want to tackle that?
Yeah, so I can speak from inside the hospitals, for those of us that are delivering that care. So, full transparency, I grew up and was raised and trained in Chicago, and I chose to go rural. And it's a very different work environment. You wear many hats. So my team, again, to kind of spin off of what was already said, we escalate things rapidly. If I have an issue with a surgical patient, I don't hesitate walking down to the surgery department and talking to the managers and directors. So we're not as siloed as what my tertiary center counterparts will be. So we are able to pivot sometimes a little bit faster. We have less layers to communicate to. And so I think that's one of our strengths. That big picture is really well known by every leader on my team, because they're not just in one department, they're in multiple departments. And so that also, I think, helps us with communication and collaboration, which I think is key in rural areas, because we don't need to just collaborate inside our four walls, but we want to raise healthy communities, right? So we form those partnerships with other healthcare teams because we can't deliver it all, because we're also usually leaner, we're smaller, we can't provide all services. So that collaboration probably is part of our infrastructure right from the start. Related to programs that are really key for hospitals to keep their doors open are things like Medicare dependent hospitals, rural referral centers, critical access hospitals, sole community hospitals, 340B. Without those, financially it'd be really difficult because, again, rural areas, we have high low income, high aging populations, so our governmental payers are much higher than most of our tertiary centers. So those programs keep our doors open and allow us to continue to provide that best practice. So what we do, same quality metrics, we perform top of the bar, receive multiple grade A's, and it's because we are able to have the capital to provide the services to those community members. And again, like was mentioned, minutes make a difference in a diagnosis. So if we were to shut down these facilities, our ability to have positive outcomes for stroke patients, for heart attacks, I think we'd see those numbers dramatically decline if we didn't have that financial support and we saw more closures.
Yeah. Ben, do you want to tackle it?
Yeah, thank you. And it's a pleasure to be here today. As I was born and raised in Nebraska, still have family back in Nebraska. It's also a pleasure to be on a panel with Rep. Schulten, who was a amazing baseball player at the University of Nebraska. So that's also I think a lifetime achievement for me. But yes, speaking as someone that still has family in rural areas, and in my work here at Families USA, we think a lot about health policy that impacts people in rural areas, and just like Dr. Yarrow and Dr. Jonk mentioned, I mean, it's when you think about how people access care in their communities, it's through their health coverage. And we know that people in rural areas are disproportionately covered by Medicaid, the Affordable Care Act, and a number of folks living on who are covered by Medicare as well. So when we think about the programs that matter for people in terms of how they get their prescriptions filled, how they get to the doctor, should they need services at the hospital, it's those programs that we really prioritize and think about.
Thank you. And second up to the host is always a good thing. So thanks for that. Second question, I'll start with Julie. What community partnerships have been most successful in coordination with health providers?
Local health departments are key. I think the pandemic showed that. So I would say, if you haven't already established a relationship with your local health department, you need to do it now so you can form that trust and understanding of what we do. Our state hospital associations are key because they allow us to form those collaborations and those relationships with others across our state. I'm Southern Michigan, Northern Ohio. So I also have a lot of patients that cross borders. So it's key also to not just stay within our own state's footprint, but also to go across state lines because that's where our patient population moves. Care pregnancy centers for us are key, particularly as we're seeing maternal fetal outcomes worsen in our areas. Housing. So safe housing connections, again, it's collaborating with others in our organizations so we can do those handoffs, those transitions of care that we talk about, but that we also make sure when we are sending folks out after an acute crisis, they don't rebound and return back to us. So the safe housing and transportation networks have been key. My county is 750 square miles. So even though I consider myself rural, not remote, I do have individuals that come to me that drive 45 minutes or an hour away, and transportation can be an issue for follow-up. So again, reaching out to others within my community that provide that service, because we can't do it all, is key. Those are a few of them.
Yeah, my mother was a public health director, and so I always appreciate people talking about the public health centers and hyping them up a little bit. And as somebody who lives in a tri-state area, I definitely understand the difficulty of the borders and how policies all work together. So how about Yvonne? Do you have some community partnerships that have been successful that you've seen?
Yeah, so I'm going to speak from some work that the Maine Rural Health Action Network has been tasked with, or we tasked ourselves with, I should say. This is a group of rural health experts that get together in the Northeast and try to put together white papers and some informative pieces that will help members of the legislature, for example, understand what's going on in rural. So one of the things that we've done was we put together what's called the informed community self-determination process. It's something that has actually been picked up by NASEMSO and some of the other EMS organizations as a template for communities to get together and figure out what resources do they have and how what kind of service do they actually want, to implement within their communities, and what would it take, what does it cost, and what are their revenue sources to support these EMS services. But another example that's been going on in Maine is the rural health. We call it RCHIP, but it's the Rural Community Health Improvement Partnership. And this is an initiative, it's a pilot project where we've had 3 rural regions in Maine pull together their community partners and try to address the health-related social needs or the social determinants of health, some of which Dr. Yaroch has brought up. So, for example, transportation, housing, the other things that come into play and probably make just as much of a difference as going to your primary care doc, right? When it comes to trying to stay healthy. And so the idea was to give them some seed funding to put together a planning process around identify what those social determinants of health, what are the most pressing needs? Is it transportation? Is it housing? Is it what? Is it, opioid abuse? What is it? And then, try to figure out, well, how are we going to address these issues? And so those are some of the community partnerships that have been going on, at least in the state of Maine. The biggest one really, that I think has really been key are the EMS groups. At least hands down, it takes a community, right, to pull together an ambulance service. But the other factors that Dr. Garrett mentioned are really important, the social determinants of health. I also will say that, the hospitals have been tasked with trying, at least the FLEX program has been trying to support critical access hospitals in their quest to make a difference in their communities and pull together those partnerships. So there's a lot of work being done in that arena. So that's
great. Yeah. So next question for Ben. What role does affordable health coverage play for patients in rural communities?
Yeah, happy to take that one. As I was mentioning before, there are a number, there are, a disproportionate number of rural Americans who are actually covered by Medicaid. It's not uncommon in some rural counties for 40 to 50% of kids in rural areas to be covered by Medicaid. Low income seniors are also covered by Medicaid, and we know that around 20% of adults are on Medicare, are in Medicaid, and that Medicaid coverage for these for low income seniors who have higher poverty rates and lower income than in other parts of the country is vital to ensuring that they get the care that they need. In terms of the types of care and coverage that you get, again, this is being able to get your prescriptions filled, treatment for diabetes. We know that that Medicaid is also vital form of coverage for pregnant women. So, thinking about obstetric services, labor and delivery, prenatal care, postpartum coverage, or postpartum care, rather. These are all the kinds of things that, folks get through their coverage and needs to be there to really ensure that they're able to meet all of their health needs throughout the year, no matter what may come up.
Oh, that's great. I think this is a good segue to next question for Julie. In rural communities, how do patient population mix of payers, so like Medicare, Medicaid, private, uninsured, impact a facility's bottom line and financial stability?
So it doesn't make it easy. So
Yeah.
so again, my organization's 11 hospitals, and we have critical access, rural, some remote, mid-size, and then tertiary. I can say for most of our rural or critical access, our governmental payers are at least 70% of our payer mix. Couple sites probably are closer to 76%. So, when you look at our charges, we collect much lower than our centers that have a private payer mix. It could be pennies on the dollar from a Medicaid versus, 41 cents on the dollar, and that's huge. So again, some of those governmental payers that help us, 340B, Medicare dependent, those are vital to us to survive, because it kind of helps us with those gaps that we have in payment, because of that high governmental payer. And again, most of my rural areas, the aging population is the fastest growing. And then we talked about maternal fetal. 80% of my babies are Medicaid babies. So, those payments and additional dollars that can be tagged on to those populations allow us to keep our doors open.
Yeah. That's great insight. Um, Yvonne, so we're going to be talking about fentanyl and opioid crisis in a later part of this afternoon. But have you seen the impact of opioids in your rural practice?
Yeah, so I'm not a medical provider, but I can say that we have amongst the highest rates of opioid abuse in Maine, in the U.S., and so it is quite an issue. We have centers that are dedicated to trying to address the opioid crisis. I know from our rural EMS folks that that's something that they have been really grappling with, is to provide the appropriate care for people who are going through an overdose. And so I should probably turn it over to someone who can talk about the practice side of things, but at least from a rural research point of view. And so I direct one of 7 centers that are focused on rural health issues, and our center specifically addresses access to care. That's sort of our niche. And so access to medication assisted therapies and et cetera are very important. But with that, I'll turn it over to and the problem has not been going away. It's gotten worse. And it's definitely been targeted towards both our vulnerable populations, which rural, elderly, and our youth. So it's quite an issue, and it doesn't seem to be going away. It's getting worse.
Dr. Julie, do you want to?
Yeah, so I think the pandemic really made the numbers of opioid abuse rise. People were confined to home. We're social beings. So I think that made it worse. I just want to say this is not unique to rural or urban. Again, I think choosing to work in a rural area, I think maybe the awareness or the communication about substance abuse is not as easily spoken in rural areas, or there could be more denials with it, has been my experience as a clinician. When you try to get in front of prominent community members and say, we've got to start addressing the issues, not just at home, but in our schools. All hospitals have to perform community health needs assessments. I believe health departments, many of them do similar studies, and all of them show a rise in narcotic abuse in all generations, which is really sad. I mean, generations starting at the age of 5. So this is where, again, access is key. It was commented, pharmacy supported therapies like methadone clinics in rural areas are difficult, because you've got to get providers that are willing to do that and trained to do that. And that can be a struggle in a rural community. But there are some creative solutions. Again, EMS has been mentioned. We've done Narcan distribution. So getting EMS, local law enforcement to carry around these Narcan kits, or giving out Narcan kits like in libraries, having sharp container access in maybe non-traditional areas. And those can be difficult conversation, particularly, I hate to say this, but conservative areas where we're going to say, hey, in libraries, we need to put sharps containers so people can go in a safe environment and drop off those needles, so we don't have additional issues with HIV and hepatitis. But also, we need to really be looking at disposable bins for drugs. So again, when our family members pass away and there's prescription bottles sitting around, we need to get those out of the house so that the grandkids or the other kids don't have exposure to them. And, it's difficult for people to know where they can go and where they can dispose of those. So I highly encourage, some successful areas is having drug drop-off areas that are easily accessible 24/7, no questions asked. You walk in, you drop them off, and you walk out. But it's a rising concern. Mental health is a rising concern, and until we can combat both of those, it's not going to go away. And it has to be a collaborative effort. This is really in rural areas. It's got to be your county commissioners, your local health department, your schools coming together and all saying what solution can we bring to the table.
Yeah. Okay. I think this is a great segue to this next question. When we talk about innovation, so what are some examples of innovation in rural areas that have led to improved healthcare access or healthcare outcomes? So, Ben, I'll start with you. If you've seen any innovations or work on anything.
Yeah, absolutely. I think one of the main things that I think we need to talk about in this country is looking at how we are paying providers. We listen to the payer mix that Dr. Yaroch's dealing with, and it's not uncommon across the U.S. when you have a disproportionate number of folks who are on Medicaid, and we're paying those providers oftentimes the least. It creates some really problematic incentive structures within the healthcare system. So I think that's the first place to start, to make sure that we're really balancing how we pay providers in a way that's more realistic for the mix that providers are serving, especially in rural areas. And I think that also means, I think, getting away from, paying by volume and looking at different ways to pay for, in the maternal health context, for example, it may make more sense to actually pay providers to leave some of those hospitals, to let the hospital beds stay there and open and available, even though it's not full. So if we sort of shift, our mindset from, only paying for procedures and services, and think about, more the needs of the community and the needs of the providers, I think we can come up with some clever solutions that can keep providers in the community. I think the other thing that's really helpful is thinking about the what providers you're letting perform which services. This is another example that comes up in the maternal health context a lot. And that's really ensuring that midwives are licensed and credentialed to the top of their license within Medicaid, because that can really improve outcomes, but also allow hospitals to stay open more when they're able to balance the different kinds of providers who are providing care. I'll stop there.
Yeah, that's great. Thank you. Dr. Jonk, you want to go next?
Yeah. So in terms of models that are hopefully moving the needle, we've seen Maryland's global budget model. We've seen in Vermont they have an all-payer ACO model. On the Medicare side, it's ACOs for the most part, and trying to do a better job of coordinating care. There's shared savings program, and how is that parsing out in terms of meeting the needs of our Medicare fee-for-service beneficiaries in a, hopefully the coordinated piece actually results in better quality of care and improved health outcomes, not just, a reduction in costs. So speaking as a health economist, you always hope that these programs will put the patient first, and make sure that even if it costs a little bit more, but if there are improved health outcomes, maybe that extra dollar is worth it at the end of the day. But that said, most of our programs are all about, oh, we want to save costs, that almighty dollar. And it's true. We've been, the light at the end of the tunnel is a train, and we're at a time in the U.S. where costs have been rising out of control. We pay 4 to 5 times more for our healthcare than any other country. And why is that? Well, I think we all know why that is. It's we have a different type of system in the U.S. than these other countries, and we probably should look at the Commonwealth reports and figure out, well, what are the successful models in other countries that where they've been at least able to keep cost at a much lower level than what we're facing here in the U.S. So I think with that, I'll let Dr. Yaroch.
Yep. Before we move on,
Yeah.
I don't want to just gloss over the fact that, we do pay the most per person, per capita. Could you just briefly say why?
Yeah, well, I sort of avoided it, as you noticed.
Oh, it's okay. If we want to, that's not the point of this discussion. I didn't know. I just, that's fine.
I'm just going to say, let me just put it in a really basic way. And from an economist point of view, and hopefully this is a bipartisan statement, okay? And that is that there is nothing transparent about our healthcare market. So the marketplace, a private marketplace, works really well if price, quantity, and quality are all transparent. None of those are transparent. When you go to the doctor, you don't know what the bill is. You don't know if the doctor's doing the right thing for you. You don't know what's wrong with you. You're not buying a service because you don't even know what the service is going to be. Unless you're going in for, okay, so like a vaccination. Okay. But, in general, none of those 3 factors that are required to make a market work efficiently and effectively are not there. And that's undeniable, And so people are trying to make things transparent. Let's post our costs, our prices that we pay, for the services. But the problem really is that we can't predict when those services, are going to be needed. And so it's not like I'm going to go shopping, when I do need those services, because I'm going to go to the point of care, or EMS is going to bring me, and I'm not going to say from the back of the ambulance, oh, don't take me there, take me over here, right? That's not how it works. So anyway, so those are the basics, without getting into too much politics.
Nope, and I think that was good. Thank you.
Thank you.
So can I just echo on something? So I think Ben mentioned that we've got to really look at the licensure of our healthcare providers and maximizing that. I think that is going to be key in rural areas. So I know not all states have independent CRNA licensure. That's a game changer for hospitals. So the way that many hospitals stay afloat is your surgeries, and dropping that surgical care is key. So having certified nurse anesthetists be able to do those simpler cases, act independently, allows us to decrease our cost of care by employing anesthesiologists who right now are in short supply, where there's shortages of radiologists. I agree. I love the idea of paying providers. I'm an internist that went in a rural environment to get paid a little bit more because I'm in a rural environment. I love that thought process, because med school costs the same regardless of where you locate to have your practice. But I think really maximizing that licensure, especially as we look at mental health and some of the regulations, every state is different on how you can petition mental health. Some of it's in person. Some are now letting telehealth. Some can let an APP be a second cert, that needs to be standardized, and maximizing those licensures. Social workers need to be looked at and how we can use them more efficiently in mental health, how we could leverage mobile clinics. So again, we keep making our customers come to us, but we have all mentioned transportation is an issue in rural, it's an issue in urban, and how we reimburse telehealth or mobile clinics and windshield time needs to start being looked at, because there are people that are willing to start practicing medicine outside the box, but there's no compensation model for that. And we've had huge success with mental health, doing mobile clinics, and also bringing clinics inside of school systems. So again, you figure a school, the kids are there, they'll come, and the parents that pick them up can also be seen. So we're going to where the customer is. But reimbursed models are a little bit different. We also have mobile units that take food out into our community and take food, food box, senior box, so that people can get 1 apple, 2 carrots, and can afford it. So I think there's a lot of creative solutions out there. What it comes down to is how we get paid for those solutions is usually much lower than the traditional models. I also think that I agree keeping some beds open. Look at quality metrics. We all should have the same quality metrics. So pay us for our quality. So if a midwife is performing the same quality, then look at if they have high governmental payers. Is there some incentive pay that we can give them because they're hitting quality metrics and keeping their doors open?
That's a lot of great things to think about there. Thank you. And that segues again into a good question that we had in the Q&A. The previous session has talked about mobile health clinics, and you mentioned mobile food. What do folks feel about a solution, especially in the super rural places, populations? Do we feel like mobile units and mobile things are a good idea? Are they a good way to reach folks? Dr. Yvonne, you want to go first?
Yeah, I was remiss when Dr. Yaroch had mentioned mobile integrated health. It's one of the sustainable pathways I think that EMS can take on, as well as community health workers, community paramedicine, and telehealth. So all of those, those inputs into the process of providing care out into the community, as opposed to expecting community members to go to, a primary care office. They often face transportation barriers. They face insurance. They're often underinsured. And a lot of times the EMS folks are telling me that they are often the only touch point when they go out into those communities for those rural populations. They would not get any care if it wasn't for EMS going out there. Now, in part, EMS cannot charge for these services unless they bring the patient to the hospital, which is a big problem for them because, how do you sustain a service? It's not like, a free-for-all. They have to, make ends meet. But again, a lot of these EMS services are staffed by volunteers. So it is community goodwill, at its ultimate, that's an ultimate example, I guess. But our volunteer base is definitely waning. And so anyway, the mobile integrated health is, I think, something that HRSA has picked up on. There's a group in Missouri that won an award for, Justin Duncan and his group. Actually gained some recognition for the work that they're doing along those lines. So what was your initial question though? Did I answer it? Because I get so excited about the mobile integrated health that I go down that road. Yeah.
No, it's just in general, do we think like a mobile healthcare unit is something we see that we should look more into? Is it a positive thing?
Oh, that's an easy yes for me.
Yeah.
And especially if you listen to the EMS community, they really are keen on trying to shine a light on the services that they do and how it actually saves, a lot of these frequent flyers from ending up back in the ED. If they can go out and make sure that they look at their medication management, for example, and make sure that the refrigerator works and that they, that they have a steady supply of insulin, or, that they're really quite instrumental. And I don't think there's been enough evidence so far that has documented the the positive impact on patients' lives. And yes, the cost savings come along with that. But in general, I do think it's here to stay, and it's really gaining momentum.
Yeah. Dr. Julie, do you have any units like that, mobile units, or are you guys just all
We have done that. Yeah, we've dabbled in that, but with the nursing shortage that's also across the nation right now, we can do more touches if we centralize our nurses inside the four walls. So I will say mobile clinics is a manpower issue.
Okay.
Again, mobile clinics work in rural and urban environments. So, school clinics, getting out to where, teen pregnancies, do prenatal checks inside the schools and the nurse's office. There's so many opportunities we can do to improve on it. But yes, we've done mobile clinics with mental health. We've done mobile food clinics, where we also make that as an educational opportunity on diabetes, heart failures. On the EMS side, again, EMS can't be the sole solution because many of us in rural areas have a few EMS, and then when they're transporting patients 2+ hours away, you've just lost your unit for 4 or 5 hours out of that day. But with technology now, a mobile EMS can go in, do a blood pressure, do an EKG, and you can have an ED provider stationed in that hospital review that and give a heads up or a thumbs up to support that the patient's stable. And the EMS are great communicators. They're trusted in the community. They're well respected by everyone. I think they have great reputations, and it's a great resource. But again, it can't be volunteers, right? Volunteers can only offer so much time. But I think there are a lot of creative solutions, but I'm going to add on there's shortages, and we got to figure out how to increase, the shortages in nursing, and because that's a great area for nurses, for techs to be utilized, not so much physicians. You can put them in your higher acuity area, but we got to figure out how to get another pipeline of talent to be able to do those mobile units. And you've got to look at the payment structure, because right now we get paid for the number of lives that we touch. When you're in a mobile clinic, you have a lot of windshield time, so you're not going to touch as many lives, but you got to pay the same salary to those folks.
Yeah. That's good points. I'm glad you mentioned pregnancies, because that brings me to another thing that's here in the state of Iowa. We are losing a lot of OBGYNs. I know when I was running for Congress, there's a significant town, 5,000 people, lost their one OBGYN, and now, how does a town of 5,000 people expect to grow when they have to travel over an hour just to get regular care? Can you talk about how reduced access to delivery services in hospitals, reduced access to pre and postnatal care and reproductive health in general for women living in rural America? And it's probably not the appropriate thing to do, but I'm going to ask the guy first, just because he is up.
Yeah, no, I get that a lot, having worked in the space. So,
yeah.
But having worked in the space a lot, the one thing that I think that we've all got to do a better job of doing, and that's listening to women, especially when it comes to things related to reproductive health. In terms of what works in rural areas, we've already touched a little bit about increasing access to midwives. Dr. Yaroch talked about paying for outcomes and those sorts of things, and I also mentioned briefly the idea of paying to keep hospital beds open and available, so that those hospitals who are only delivering maybe 30 babies a year can stay open. Another model that has shown really good outcomes, and you can do it in rural areas, it requires some coordination, is a model called group prenatal care. And this is where a provider or even an extender of some sort does a portion of prenatal visits in a group setting all at one time. it's shown remarkable outcomes in terms of reduced C-section rates, better infant health outcomes, reduced stress on mom throughout the duration of the pregnancy and even after delivery. So remarkable outcomes, but because you're providing it in a group setting and you've got to sort of get everyone together, it's something that can be challenging when it comes to coordinating, and so you want to make sure that the reimbursement is there for those things, like driving to get to the community that's convenient for women in the area. But also to make sure that the staff time that it takes to coordinate such a program also works. So wanted to plug that as well.
Yeah, it's great. Dr. Jonk, do you?
Yeah, I would just add that, in addition to the workforce issues that Dr. Yaroch had brought up, in rural, the number of hospital closures, and along with that are ambulance closures. So the number of folks out there that are able to, actually assist women when it comes to deliveries, is declining, and that's very, very concerning. We've been promoting the use of telehealth, and I know that that's some of your upcoming, questions for us is around telehealth, but so coaching, for example, your primary care provider that ends up, delivering babies in the middle of the night, or even EMS, delivering in the back of their ambulance, could be a very useful tool. But in terms of, trying to develop a pipeline, I think that's, I'll turn it over to Dr. Yaroch, because I do think that working at the top of your scope is a really important piece here with PAs, NPs, etc. And if we can, figure out how to improve access through the people who are actually on the ground in rural, as well as entice, additional folks, but using a multi-pronged approach, I think is very much necessary in this particular arena. So I'll turn it over to Dr. Yaroch, if that's okay.
You're doing my job for me. Thank you.
Yeah, I think so. You also got to understand the world of rural OB. So it's not just your one provider that needs to be competent and up to date. It's also your clinical supportive staff. So unfortunately, as your deliveries drop, the competency of your staff can be an issue. This is where I think technology has really helped us in rural areas. We now have mannequins that we can train our staff on routinely and have them go through those high-risk pregnancies by, basically simulating a fetal demise and allowing them to react to that. I also think this is where collaborating with larger organizations and allowing our staff to kind of rotate through, but there's licensure issues around that. So we got to start looking at how do we allow our staff to move maybe across state lines or from one center to the next without risk to their licensure, so that they can shadow in larger facilities where they can kind of jumpstart their knowledge on deliveries and high risk and what they can encounter. Midwives is another piece, I agree. But I go back, family practitioners used to do a lot of deliveries. And in med school, we're getting more and more of our primary care is going into specialties. They want to go into heart, lung. And I think we need to look at how can we incentivize, romanticize rural health again. I had a strong affiliation that is exactly where I wanted. That's exactly where I went. I have no regrets. I love it. And we need to start figuring out how to get that pipeline of maybe family practitioners to get back into those general practitioner residencies where they learn how to do OB. And they're out there. And when I listen to my counterparts through American Hospital Association, I think there are some areas that have done it really successful, where they've been able to kind of encourage more family practitioners to go that path. But there's still a lot more opportunity to utilize them in this space.
I want to stay with you for 1 second, because I think this is an important question. about recruiting and retaining our workforce. Have you seen anything that's been successful, or what do you think we need more of? I mean, other than skilled workforce.
Yeah, and so when we talk about pipeline, it's not just providers, it's not just APPs and physicians, it's respiratory therapists, it's CT techs, it's pharmacy technicians, right? So everybody wants us to lower our cost of care, and so it requires all levels of that. So I think, in rural area, we kind of do that grassroots approach where we try to get into the high schools and the grade schools and encourage people. I mean, the pandemic scared this generation of workforce to go into healthcare. What they do, they all want to do outpatient. They don't want to do inpatient. So we need to get out there and try to answer those questions and those concerns, but also explain to people you don't have to be the top of your class. There are so many different roles in healthcare that make a difference, that make an impact, and you don't have to commit $200 to $500,000 in debt. There are 2-year programs that you can be in healthcare, and everybody's going to need healthcare, right? I always say you're guaranteed a job. You can work in whatever state, whatever environment you want. You get benefits. It's amazing. Not to mention, if you're a people person, there's no better job in this world. So I think we need to look at the licensure that was, as we'd already mentioned. I think we need to be creative. There's turf wars, who can do what procedure. And I think because we're not seeing as many people go in healthcare, I think we've got to stop having these turf wars saying OBs should only do this. We need to start saying family practitioners can do this. APPs were mentioned. If we're going to let advanced practice providers do more, then we got to look at those training programs. They can't all be virtual. You got to touch patients. So maybe if you're going to go into things like OB, there's extra clinical hours where they're doing more deliveries so they feel comfortable, because having worked in a rural environment, you don't have 50 mentors around you to help you if something goes wrong. It's just you. And so I would say in a rural environment, you have to be more confident than my colleagues in a tertiary coming out, because it's just you making those calls. So I think there are a lot of people that want to go in it, but it is a greater struggle to recruit. And it's also because dual income families now, I can say this prior to me, you had more providers that, there was a spouse that just followed that physician to wherever they went. And that's one of my greatest challenges nowadays. Nurses, physicians, is in my rural areas, I don't always have an economic opportunity for the spouse. And that can make it a little bit more challenging. I think since the pandemic, there's a lot more work from home environments that spouses are able to do that fulfill that need. But that's also a challenge in rural that's really unique to us, that we don't see. Housing also is a constant struggle in some rural areas. I don't necessarily always have the housing to support my talent. We seem to, speaking to other rural counterparts, we have more housing shortages than some of our urban entities, and that can make it really difficult. If I don't have different housing for all skill sets, for all salary levels, recruiting is a huge challenge. Does that answer your question?
Well, yeah, very much so. And you gave me hope, because I don't have to finish top of my class. You're speaking my language.
No, you don't. You don't. No. You got to be able to communicate. Yeah.
Right. Ben or Yvonne, do you have anything to add to that? It's okay if you don't. Okay, that's fine. So I guess we're wrapping up here. We just have a few more minutes. And one of the things that I really want to do is ask folks is in this space, because we talk a lot of negative aspects of our healthcare, especially in rural. I mean, when I went around the past few years when I was running for Congress, I talked about how nearly every gas station I went to, every community had a GoFundMe, every pancake breakfasts, all that, just to pay for medical expenses. And so there's a lot of negative aspect on healthcare, and we've talked about a lot of the challenges. But I want to end things on a more positive note, and I would like to think, or would like to ask each of you individually 2 things. One, where can folks follow you in going after this? And then also, what gives you hope in the rural medical space? So those 2 questions, I'll start with Dr. Yvonne. Do you want to?
Yes, what did you mean by where they can follow me?
Like just if you have a social media account, or if you
Okay.
produce work through your job or anything like that, where
Yes.
can folks follow your work? Yeah.
Oh, okay. So, yep. All you need to do is look at the, Google Maine Rural Health Research Center, and you'll find me.
Okay, it sounds
as,
good.
as long as, and as well as our Twitter account. So
There you go.
that's on there on that website. Um, and then what was the second question? Oh, what gives you hope?
What gives you hope? Yeah.
Yeah. Well, I was born in a critical access hospital. I was born and raised in the Midwest on a farm. It was the most beautiful upbringing you can imagine. I was able to run around and, with no fear of, where my parents never worried about where I was, right? And so I don't know if that's necessarily changed or not in rural, but it certainly was a beautiful way to grow up. They often talk about how farm kids, really are grounded, well grounded, work ethic, strong work ethic. I think that is still true. I see it within my own family members. I come from a whole group of farmers. My sisters are pretty much all farming except for one who's a nurse. So I'm very proud of them, and they're serving on EMS. And so, there's pride in rural, that you cannot underestimate how strong that pride is, and it's community pride. And they really, stand up and try to, support each other. And that is still there. And that gives me hope.
Wonderful. Ben, do you want to go?
Yeah, sure. Yeah, I think similar to Dr. Jonk. I also think about my family who still lives in Nebraska, and my wife's family lives in very remote parts of Nebraska and Kansas, and yeah, it's rural Americans always find a way to get things done.
Yeah.
Thinking about going back there at holidays, and someone's always got a new business, or there's a new storefront in towns where it seems like it would be impossible, but it's not. And I think there's also a great deal of interest across the country to help and make sure that things work in rural America. There's no shortage of legislation on both sides of the aisle that but we find good policy ideas everywhere. And the things that we look at and think about, as long as it's protecting Medicaid, the Affordable Care Act, Medicare, making care more available, making care more affordable, especially for people in rural areas, that's good policy. And we're confident that people in rural America can they know what they need better than anyone else, and will work hard to make sure it gets done.
Wonderful. And where can folks follow you?
Yeah, you can follow my work at the Families USA website or on Twitter at Family Health Ben.
Wonderful. Thank you. And Dr. Yaroch.
Yeah, so I'm happy if the organization wants to share my work email. It's julie.yarodio@ProMedica.org. Or just look up ProMedica Health System, and you can usually locate me on that. What am I hopeful for? Just the fact that we're able to share our story, that this organization, this group took the time to reach out and let us have the opportunity to share our story, share our experience. I think the more we communicate to each other, the more we try to understand each other's world, the more successful we're going to be in building healthy communities. Because, again, I don't mean to take away from rural, but rural, urban, we really need to start focusing how we come together and prevent negative health outcomes, and how we build a healthier community. And rural America is vital to our economy. We mentioned, typically when I see somebody and I have to take them off of work, that's a huge blow to that family's financial stability. Because on a farm, every set of hands matters. It really impacts the economy of our community. And having hospitals and having access to care makes a difference in the outcomes. We made a comment that minutes matter. So if we start closing down further rural sites, we're going to have more people that are going to have negative outcomes from strokes and heart attacks, and that's going to lead to more financial strain on the country as a whole, because more people are going to require additional assistance. So just I'm hopeful that we get to continue to share our story. I hope we continue to put our heads together to figure out how we keep access and equity at the front of mind, because in the long run, financially, it's going to be a win. And I'm hoping that we can romanticize rural health, because I agree, I can imagine living anywhere else. And there's a generation out there that I think would find it as enticing as we do. We just need to let our stories be heard.
That's wonderful. I think that's a great way to end this. So Yvonne, Julie, Ben, thank you so much for taking the time. Thank you for all that you do, and for just joining us here and taking the time to be part of the Rural Progress Summit. Before I kick it back over to Heidi, I just want to let folks know that at least in the state of Iowa, it's a primary day, so go out to vote. I got to vote for myself this morning, which is always a kick. I don't have an opponent, so I'm fairly confident on this one. But I'm now going to turn it over to Heidi Heitkamp for the day's final featured conversation, a discussion with Michael Runningwolf and Ian Her Many Horses, with the co-founders of the Lakota Code Camp. A reminder to our viewers on Zoom, please return to the lobby and select the featured session Lakota Code Camp from the list of sessions. For our viewers on Facebook, the stream will resume in a new post momentarily. Thank you, everybody.